and your continued participation means that you consent to being recorded. Second, if you'd like to ask a question, which we heartily encourage, please type your question into the chat box. We're going to have some designated times during the program when an MCA staff member can pose the questions to our presenters, and we will have, so no need to raise hands. We can address those during those set times. And then finally, be sure that questions and comments don't contain any patient information or protected health information. We really want to make sure that we are sticking kind of to the subject matter at hand tonight. All right, well, let's go ahead and get started with Dr. Lyndsey Kilgore. Dr. Kilgore is an assistant professor of surgery in the Division of Breast Surgical Oncology at KU Medical Center. She attended medical school and completed her general surgery residency at KU before completing a breast surgical oncology fellowship at the University of Texas MD Anderson Cancer Center. At MD Anderson, she held several leadership positions, participated in cutting-edge research, and was named Fellow of the Year. Her current surgical and clinical interests, clinical and research interests include treating high-risk patient populations, breast cancer, and treatment-related lymphedema, and clinical trials. One comment of note is that Dr. Kilgore will unfortunately not be able to accompany the rest of us for a question and answer portion of today's meeting. But we're so grateful she could be here to share this important information. She has been so kind as to share some contact information if there are any pertinent questions left after the meeting. And thank you all so much in advance for your understanding. Take it away.
Thank you so much for that kind introduction. I will share my screen so we can go ahead and get started. I'm super excited to be here today, and I'm really honored that you all asked me to present. Having been back in practice for a little over a year now, it's been very exciting to kind of share some of the newer techniques and knowledge that I gained at MD Anderson, as well as come back home. So, can you all see my screen? Great. All right. So what we know, don't know, and wish we knew about breast cancer. That's kind of the title of all of our topics today, because there's a lot of things that we've grown a lot over the years, but there's a lot of things we still don't know. And as you guys know, a lot of our clinical trials play into this research. So I'm going to be speaking particularly about breast cancer, and then my other colleagues will be speaking about their cancer specialties. I have no financial disclosures. So as most of you know, 1 in 8 women in the US will develop breast cancer within her lifetime. And if you want to know about men, it's 1 in 833. There's an estimated over 287,000 new cases of invasive breast cancer in women, and an estimated 51,000 new cases of non-invasive, meaning ductal carcinoma in situ, the stage 0 breast cancer in women. There's an estimated 2,700 new cases of invasive breast cancer in men. So what we know, we have learned a lot over the years, and screening mammography really helped us. It reduced breast cancer mortality and allowed us to decrease it by a relative risk of 20%. There have been significant improvements, not only though in mammography, as we have 3D mammography and tomosynthesis, but we also have improved ultrasound techniques, and we had the development of MRI of the breast. I showed a picture down here of some MRIs, and as you can see, the images that you get from MRI are phenomenal. The reason why is because a woman lays in the tube here and then gets an IV with contrast. So we can actually see the enhancement, wash out and wash in kinetics of the breast. This lets us really differentiate background breast tissue, especially in women with dense breast, and then really differentiate what is actually tumor. Breast cancers nowadays are really identified at earlier stages. But we got to keep in mind, although we've made great strides, not all breast cancers behave the same, and we really need to treat them individually. I can't emphasize it enough. You'll have patients come in with a breast cancer diagnosis, and they're like, well, my friend, my aunt, my, significant other, they had this diagnosis, and everyone's breast cancer is very different. And so I just showed you here, the common things that we look at are tumor markers, ER, PR, HER2 expression in the breast. And then we also, on final surgical pathology, and even sometimes before deciding if we're going to do surgery first, we utilize Oncotype DX, which is a breast recurrence score. And this number really helps us predict those patients that would have a strong benefit from chemotherapy who may otherwise not, and also has allowed us to not give as much chemotherapy to patients. And this oncotype score is based specifically on the patient's tumor from their surgical pathology or their surgical biopsy. So it really has transformed our treatments for patients. So what we know, breast cancer has well been overtreated with surgery over the years. And over here on the right is a picture. We used to do the Hallstatt or radical mastectomy, where we removed the entire pectoralis fascia or muscle, and then removed all the lymph nodes under the armpit. Then we knew that was overkilling it. So then we went on and did the modified radical mastectomy, where we leave the pectoralis fascia intact or the muscle intact and just take the overlying pectoralis fascia as well as the lymph nodes. So that transition from Hallstatt radical mastectomy to total mastectomy was based on the NSABP B04 clinical trial. And I'll try not to bore you too much with all these clinical trials, but a lot of breast has advanced over the years because of all of these. So I have these in here, and if anyone has specific questions about the trials, don't hesitate to reach out to me, because a lot of our breast knowledge is constantly advancing based on ongoing clinical trials, and why it's hard for a lot of general surgeons who are not fellowship trained to keep up because it's constantly changing. So then we had the transition from, everyone was getting mastectomy for any size cancer to where we proved that lumpectomy with radiation was equal in overall outcomes and survival. That was based on the NSABP B06 clinical trial, as well as the Milan study, as well as EORTC 10801 clinical trial. So some other things that we know about breast cancer. Here at KU, we actually now offer intraoperative radiation therapy. This is a one and done intraoperative radiation treatment. So we're now saving patients the 3 to 5 weeks of daily external or traditional beam radiation treatments. This is for those, specific well-behaved, hormone-positive, smaller-sized breast cancers. And you as providers don't have to always, think about it on, who would qualify, who wouldn't, but that's kind of the overarching thing that we evaluate when patients are sent to us. So for those patients, the lumpectomy is performed in a similar fashion. And then once the lumpectomy is performed, we stick that radiation probe, that Ember probe in there, and then deliver radiation from outside the room for a specific duration of time based on the size of the probe that's needed. And like I said, for the patients that qualify, it's one and done radiation treatments for over 85% of patients that undergo it. The only things that would make them need additional external beam is if we were surprised and lymph nodes were found to be involved or the cancer was a higher grade aggressiveness. So this is a great option for patients. Overall cosmesis is obviously improved. And then patients' time and cost driving to and from radiation treatments. And then, there are even some studies that are suggesting improved overall survival because they're not getting whole breast radiation. So cosmetic outcomes, so they significantly impact women following breast cancer treatments. A lot of people will say, oh, it's just a breast. It's not. This makes a woman feel like a woman. And so we've really evolved with our oncoplastic techniques over the years. Particularly, we now offer nipple-sparing mastectomies in appropriate patients. So some of the things that we think about for patients that we offer nipple sparings to are where's their tumor size, making sure that it's not multifocal tumor, and that they don't have too large of breast or too much ptosis to allow the nipple to survive. But this is an example over here of a patient who underwent nipple-sparing mastectomy, and it looks fantastic. You can also see that she has a scar on her abdomen, and that's because she underwent reconstruction with deep reconstruction, which is the deep inferior epigastric perforators, where women get like a tummy tuck, and then the plastic surgeons use that belly fat to recreate their breast. And that's something, again, that our KU providers are extremely skilled at, as we have microvascular fellowship trained plastic surgeons who are able to offer this, where not a lot of people in the region and even in the country can. We also have, immediate versus delayed reconstruction, whether it's with implants or, like I said, using your own tissue, whether it's the belly, muscle flaps, etc. And one of the newer things that we've, done a lot recently is oncoplastic reduction mastopexies with lumpectomy. So what that means is when a woman gets a lumpectomy, if they have large ptotic breasts, we can lift and reduce that breast after we remove the lump and then make the other side match. So lots of women who have had trouble with large breasts over the years, back pain and other things, it's kind of a silver lining for them that they can get that reduction at the same time and have just a great of us, oncologic outcomes, because then they get the lumpectomy and the radiation with equal survivals and not having to undergo a mastectomy. Lymphedema is a significant morbidity associated with nodal surgery. I'm sure lots of you had heard of patients that have had lymph nodes removed and then develop that arm swelling following their lymph surgery. It can happen in the upper and lower extremities, but obviously in breast cancer, we deal with it most in the upper extremity. But it's because when lymph nodes are removed, those channels are damaged. And so the way I describe it to my patients is that it's kind of like a traffic buildup. When you start taking out some of the highway bridges, traffic tends to build up back in the arm. And so the body has to figure out how to recreate those bridges and get traffic rerouted. And so, at KU, we have a comprehensive lymphedema program run by specialized lymphedema nurses. We have the involvement of occupational and physical therapists when needed. And so we've published on it here at KU that if we detect it early, before patients even notice swelling, so on our machines, we can actually reverse it and get rid of it completely. So we know that that's a very bothersome, a strong morbidity for patients. So we've made great strides with that. One thing I'd be remiss if I didn't say is that multidisciplinary teams are really key to breast cancer management. It's not just the surgeon, just the medical oncologist, just the radiation oncologist. There's the radiologist who makes the diagnosis, who helps us formulate treatment plans. Then you have the radiation oncologist, the plastic surgeons. We have all our lymphedema nurses, our therapists that are involved. And then, even clinical nurse navigators and coordinators and patients that help us make this team run. And it's really important when you think about a multidisciplinary team that the patient is the center of focus. The patient is the one ultimately making decisions. I tell them all the time, we can make recommendations, but it's ultimately your body and your choice what you want to do, and I'll just provide you the information. So some other things that we know is that the axilla has also been treated over the years, so the armpit. We've shifted from doing axillary lymph node dissections on everyone, where we remove all the lymph nodes under the armpit or levels 1 and 2, to then just doing what's called a sentinel lymph node biopsy, where dyes are injected into the breast. We see which of those dyes are taken up by the lymph nodes under the armpit, and then we remove those specific lymph nodes that take up the dyes. Because it's like the drainage pattern of a breast. If cancer is going to go somewhere, it goes to those sentinel nodes first. Those are kind of what I tell my patients are the guards to the castle being the rest of your body. So if there's no cancer in them, we feel much more confident that we don't need to do much bigger surgeries to remove the rest of the lymph nodes. And that came from NSABP B32 clinical trial. We even have shown that we can do sentinel lymph node biopsies even after chemotherapy is given for a positive lymph node. And that's pretty remarkable that our chemotherapy drugs work so well that we can actually shrink the cancer out of the lymph nodes in the armpit and not commit them to that big axillary lymph node dissection and try to do a sentinel lymph node biopsy alone. That's based on the ACOSOG Z1011 or Z11 clinical trial, as well as the Amaros clinical trial and the IBCS G23. Sentinel lymph node biopsy alone after positive lymph node identified in patients who received neoadjuvant chemotherapy was determined by ACOSOG Z1071, Centina, and the FNAC clinical trial. So lots of clinical trials, all proving kind of the same thing. So what we don't know, which high breast lesions need to be excised? Does all ductal carcinoma in situ, that non-invasive stage 0 breast cancer, need to be surgically excised? Can we avoid completion axillary lymph node dissection in positive nodes identified on sentinel lymph node biopsy after neoadjuvant chemotherapy? So we know if the cancer is shrunk out of the lymph nodes after chemotherapy, we can do sentinel lymph node biopsy alone, but we haven't shown if there's still small focus of cancer left under there, what we need to do. And then also we're always working on lymphedema and how actually intraoperatively we can reduce rates of lymphedema. So briefly, when we talk about the high-risk lesions, there's many high-risk lesions: atypical ductal hyperplasia, atypical lobular hyperplasia, radial sclerosing lesions, papillomas, the list goes on and on. But lots of institutions have come up with care pathways on how to manage these. We don't need to excise all of these lesions. And at KU, we have a multidisciplinary team that reviews the biopsy, the radiology, draws concordance, and then we decide if they need to actually have surgical excision or if it's something that could be closely monitored. And I just briefly showed a pathway here for you all for reference about our intraductal papillomas. So we very much have, standardized pathways based on risk factors published from the data in the literature before, but obviously we take each patient into account. So does all ductal carcinoma in situ, that stage 0 non-invasive cancer, need to be surgically excised? There's an ongoing AFT25, the COMET clinical trial that you may have heard of. And this is looking at endocrine therapy and active surveillance with imaging compared to surgical excision, radiation, and endocrine therapy, which are the current recommendations. The thought is that over time in the ducts, abnormal cells build up. Then when cancer cells are found within the ducts or inside the pipes, that's a ductal carcinoma in situ, inside the pipes. The thought has always been that all ductal carcinoma in situ turns into invasive, and that's what this study is trying to show, that not all DCIS probably doesn't turn into invasive, and we've been doing a lot of extra surgery and radiation when we may not need to. The other thing that's ongoing is, can we avoid completion axillary lymph node dissection and positive nodes identified after a sentinel lymph node biopsy after the neoadjuvant chemotherapy? So all these what if. So now after chemotherapy, if the node still has cancer in it after we've done a sentinel lymph node biopsy, and particularly here at KU and at MD Anderson when we do targeted lymph node excisions, where we make sure we take out the lymph node that had the biopsy clip ahead of time to know for sure we took out the one that we knew had cancer, to decrease our false negative rate. We're now looking to see, based on the Alliance A11202 clinical trial, to see if axillary lymph node dissection plus radiation, which has been the standard of care for many years, is equivalent to axillary radiation and nodal radiation without the big lymph node surgery. So what we wish we knew, how can we intraoperatively reduce rates of lymphedema? There's currently the ARM clinical trial that's ongoing, looking at axillary reverse mapping. That's when you inject dyes into the arm and make sure that you don't take the dye or take the lymph nodes that have the dyes coming from the arm, and rather focus on the lymph nodes that drain the breast. Obviously, we want to preserve those branches and things. And then if we do have to take them because it drains into a sentinel lymph node that took up the other dyes and the technetium, the radioactivity, then we're trying to see if we can reconnect them in the operating room, just kind of loosely connect them. Whereas you'll also hear about immediate lymphovenous bypass surgery. And that's when at the time of the operation, we actually preserve the lymph nodes that take up the blue from the arm or the channels. And then the plastic surgeon comes in at the time of the axillary lymph node dissection and reconnects them, anastomoses them to the veins. And this has been really promising data on reducing the risks of lymphedema. And we're, again, one of the only people in the region and in the country that is able to offer immediate lymphovenous bypass surgery in combination with our plastic surgeons. So I know that was a whirlwind of breast cancer surgery. There's a whole year fellowship after general surgery for it, but I'm happy to take questions, or if anyone has questions, don't hesitate to reach out via email.
Thank you so much, Dr. Kilgore. We're sorry you weren't able to stay with us for more questions, but we really appreciate you giving your talk. And so we'll let you hop off the meeting, and thank you again. We really appreciate it.
You're welcome. And I mean it. Anyone can reach out anytime via email with any questions. I'm happy to answer them. Thank you so much.
So Hanlon, I am certainly a poor substitute for Dr. Kilgore, but I'd be happy to try and answer any questions that have come across.
Yeah, sure. So we do have a couple of questions. The first one is from one of our Pivot members, Charlene. She had a question of, what is washout kinetics?
Well, that's a great question. And I certainly, wish that I had the experience, as a breast surgical medical oncologist or radiologist, but I would say the coloring book version, as I understand it, is that washout kinetics relates to the enhancement in a given area of tissue on an MRI, and how long, while they're kind of taking their pictures, the tissue stays enhanced versus having that fade. So I think I can't tell you anything about how that relates to the likelihood of a cancer being present in that location, but I know that the radiologists have expertise in kind of looking at those factors to try and assess the risk of that. So I think it's kind of just that, whether something looks more bright or whether and how quickly the brightness fades.
Okay, great. And then just one more, and actually it is another pivot member. I hope I'm
Oh,
saying this
great.
right, Sherry Ling. She had a question: if a patient underwent the plastic reconstruction, will the future diagnosis of cancer be harder for her?
That's a really great question. So, so important. And I'm sure something that anybody who would be facing that kind of treatment would be wondering for themselves. So again, with the caveat that I'm not a breast surgeon or a medical oncologist, I am I am a medical oncologist myself, and can tell you that thankfully, as long as an individual is going to an imaging center that has experience with kind of breast implants as they relate to cancer surveillance, then no, it should not impact the sensitivity of breast cancer surveillance by imaging. So I would just, when considering that, I think a great place to get a recommendation for an imaging center would be from your treating oncology team, and because they will have a really good sense about kind of the volumes of this sort of work, that a given imaging center would do. So thankfully, no, with our modern technology, patients don't have to choose between a favorable cosmetic outcome and good cancer surveillance. Great question.
And that is actually it, Libby, if we wanted to move
Okay,
forward.
great. Well, perfect. Thank you so much. I am so pleased to introduce our next presenter, Dr. Benjamin Martin. Dr. Martin is an assistant professor of surgery in the Division of Colorectal and Oncologic Surgery at the University of Kansas Medical Center. He attended University of Missouri for his doctorate of medicine before completing general surgery training at Emory University. During that time, he also completed a 2-year research fellowship that had an emphasis on tumor and transplant immunology, as well as a subsequent other series of fellowship training regarding minimally invasive surgery at the Emory Endosurgery Unit and the Division of Colon and Rectal Surgery at the University of Minnesota. So his clinical and research interests include multidisciplinary care of complex colorectal pathology via minimally invasive surgical techniques. Dr. Martin, thank you so much. The floor is yours.
Thanks, Libby. Let me get my slides up here.
Sure.
All right, does that look okay for you guys?
Looks perfect.
Okay, I gotta get it back up to the front. Well, hello everyone. Thanks for having me on this afternoon. I want to thank the Masonic Cancer Alliance and the KU Cancer Center, of course, especially Dr. Doolittle for the invitation today. And so, and it's kind of apropos, this is the end of Colorectal Cancer Awareness Month, right at the end of it. I have been on staff here at KU since about the end of 2017, so about 4.5 years. And so I'm going to talk about this kind of same theme, but different topic: what we know and don't know and wish we knew about colorectal cancer surgery. And I have no financial disclosures either. So what do we know, or what is the current state of colorectal cancer in the United States? Well, colorectal cancer is the 3rd most common cancer diagnosed if you exclude skin cancers in both men and women. So breast cancer is going to be the number 1 cancer in females, and then prostate cancer in men. There's about a 4% lifetime risk of developing colorectal cancer in the general population. And as you can see on the graph on the right, Kansas and Missouri are kind of this lighter shade of blue, about 39 people per 100,000 who develop colorectal cancer. The highest is more in the South. I think Mississippi is the highest state. I think it's about 49 per 100,000 people. And colorectal cancer is the 2nd leading cause of cancer death in the United States, behind lung cancer. And that equates to about 53,000 deaths per year. And these rates have actually been steadily declining, about 1% to 2% per year since the 1980s. And a lot of that's due to improved screening, mainly colonoscopy, but also the other forms of screening that we have. that have been able to decrease that, and lifestyle modifications like less smoking. However, as you know, you may have seen in the news, there is an increasing incident in those in the less than 50-year age range. And that's going about 2% per year. And that's been going on since the late 1990s. So this is kind of a trend in younger patients. And that's probably due to a combination of factors: sedentary lifestyle, obesity, smoking, heavy alcohol use, poor diet choices with lots of processed meats, and maybe some other environmental factors. So when reporting statistics for colorectal cancer, we typically lump colon and rectal cancers together, but from a medical and a surgical standpoint, these are treated very differently. The colon starts near the appendix and goes up along the liver, kind of across over towards the spleen and the left upper side, and near the pubic bone. And so the colon is longer than the rectum and has a higher rate of cancer, about 2 times that of rectal cancer. And colon cancer is typically treated with surgery first, and then possibly chemotherapy afterwards. For example, if there are some lymph nodes that are involved. So if you contrast that against rectal cancer, rectal cancer is less common. The rectum is about 7 inches long from the pubic bone down to the anal canal, so a shorter distance. And it's in close proximity to many structures that it can potentially invade: the bladder, the vagina or uterus in women, or the prostate in men. And it has a variable lymphatic drainage in that area, so which makes it more challenging to treat. And it is treated in a different way. We typically will give chemotherapy and radiation prior to surgery. So this is very different from how we treat colon cancer. And these are, really very distinct entities, even though we kind of separate, we lump them together. For localized disease, the 5-year survival rate is about 90%. Once you get to more regional disease, meaning invasion of local structures or lymph node involvement, this 5-year survival is 72%. Metastatic disease is around 15%. So, now kind of on to what we don't know but wish we knew. In other words, things that we're researching here. And as I mentioned, rectal cancer is treated differently than colon cancer. For rectal cancer, we typically give radiation prior to surgery, which has been shown to decrease the risk of local recurrence. And everything is kind of a risk benefit calculation, and the potential consequences of radiation are things like difficulties with urination, maybe signs of radiation damage to the bladder, changes in sexual activity as a result of radiation damage, which could be narrowing of the vagina or erectile dysfunction, and then changes in bowel habits from the chronic inflammation and injury to the rectum. So there are certainly consequences to giving radiation. So are there a certain subset of patients that do not need radiation? And so there was a large trial called the Prospect trial in which KU participated. And it looked at exactly this kind of thought. And this was for rectal cancer patients and looked at giving chemotherapy alone or chemotherapy plus radiation in treating patients with these locally advanced rectal cancers. And this was an alliance trial that was performed and that we participated in here at KU. And this is the study schema. It was randomized 1-to-1 between the standard arm and the selective arm. And in the standard arm, patients received chemotherapy and radiation. And the CMT stands for combined modality treatment, which is chemotherapy and radiation in this scenario. This was followed by surgery and then chemotherapy alone afterwards. So that was the standard treatment arm, but there was a selective treatment or investigative arm in which the patients received 6 treatments of FOLFOX, which is a standard chemotherapy regimen, and then were restaged with an MRI. And if they had a greater than, the tumor shrank by greater than 20%, then they did not get radiation and they went straight to surgery. And this was followed by chemotherapy afterwards. So the primary objectives were to evaluate whether omitting radiation in some patients led to equivalent outcomes and to monitor for local recurrence and overall survival. And so this trial in which we participated is now closed. I mean, I think it was last year, about a year and a half or something ago. We're accruing data. It looks pretty promising in some of the small case series, and people have tried to kind of looking outside. There's a Canadian study that kind of tried to beat them to the punch with some data here, but we're waiting for the final results to come out on this. So this looks like something that could be practice changing, that we had quite a high enrollment in here at KU. Another avenue of research is how can we make tumors more susceptible to conventional treatments prior to surgery? And there's a peptide or a small protein called SEND1 that's selected for cancer cells that increases the uptake of conventional chemotherapy agents. And it basically gets the drugs into the cancer cells better. Sorry, my slides aren't advancing. There we go. I think this study was in a collaboration with industry, with Sen Therapeutics, and the principal investigators, Dr. Kasi, here at the University of Kansas. And so this study is in SEN1 in combination with neoadjuvant FOLFIRINOX, again, kind of a pretty hefty chemotherapy regimen, with or without another agent called panitumumab. We affectionately call this study CindyFox to make it easier, but this is, this neoadjuvant treatment with the chemotherapy, that basically means it's given before surgery. So these patients are all surgical candidates, and they're getting the SEN1 along with a normal chemotherapy regimen. And this trial is active. We've enrolled 7 patients so far. I think the community sites are being added as we speak from the last meeting I was on. It's for patients with colorectal cancer that have metastatic disease to the liver, the lung, or the peritoneum, so within the abdominal cavity. But they still have to be surgical candidates, so potentially they need to be resectable. It also includes patients with pancreatic and appendiceal cancer, so it's a little broader than what I've described as well. But the primary objective is to assess the safety of the drug. But secondarily, we're looking at tumor response at the time of surgery, in the pathology specimens, and the risk of recurrence and overall survival over time. So this is an active trial that you may see kind of soon. And then finally is an investigator-initiated trial by one of my partners, Dr. Alcaspools, in the Division of Surgical Oncology. And this is kind of very specific for something called peritoneal carcinomatosis. And this is basically means where there's been spread of cancer within the peritoneal cavity, within the abdominal cavity. And this can occur in up to about 30% of colorectal cancer patients. So this trial really focuses on surgical trial to go in and remove these tumor deposits, all visible disease, and then to give heated chemotherapy in the abdominal cavity. And this is known as a hyperthermic intraperitoneal chemotherapy, or kind of heated chemotherapy. And this is given in the operating room. That's kind of what this picture is showing, is the inflow and outflow cannulas there. After everything's been, all the tumor deposits have been removed. And this has been shown to improve survival in carefully selected patients. And so one of the main questions in this kind of highly specialized field is, what is the best drug? What is the best chemotherapy to infuse in the abdominal cavity at the time of surgery here? So, and that's what this study focuses on. And it really looks at two chemotherapy agents, mitomycin C versus melphalan. And so this study is active. It's enrolled 82 patients so far, and I think the goal is 100. And so this has been going on for a couple of years now. And so, it's really a pretty impressive and investigator-initiated study, but is active. And so, in conclusion, I think colorectal cancer is a prevalent disease with a huge, societal impact. Colon and rectal cancers are typically lumped together, but really they're treated very differently. While early stage colorectal cancers have good overall survival, we are focused on improving outcomes for patients with regional or lymph node involvement and metastatic disease. And this includes the Prospect trial for rectal cancer, which is closed with data accruing, the CindyFox trial for metastatic colorectal cancer, which is actively recruiting, and then the hyperthermic intraperitoneal chemotherapy for colorectal cancer patients. And so these are all kind of, trials that heavily involve surgery and colorectal cancer. And one of our future goals is to develop an institutional study aimed at the non-operative management of rectal cancer. And by that, I mean patients who've had chemotherapy and radiation and their tumors have melted away by all evidence, by exam, by endoscopy, by MRI. And so that's an active area where we may be doing less surgery. And we certainly have a few patients off trial that we're doing that with, and kind of intriguing. So I'd like to thank all of you for your support, especially thank the patients, who are the main driver behind all the everything we do and all the studies we do. And I'm happy to take any questions now or later.
Thank you so much. I, for one, think it's incredibly noble that you are willing to get yourself less business to help patients avoid operations if we possibly can. Han-Lyn, what questions do we have for Dr. Martin? I think we have about 4 minutes or so.
Sure. Well, that's good. There's just one question. It's from our pivot member, Charlene, again, and she asks, for the clinical trials, Dr. Martin, have you seen a difference based on age and response to the treatments, just in general?
Well, yeah, I mean, I think these giving the treatments up front as compared to giving them afterwards. So, for example, I talked about rectal cancer. I think we've shifted that way because we found that more patients tolerate those treatments prior to surgery. About 50% of patients actually, if you try to give them chemotherapy and radiation after surgery, about 50% are not able to do it. So we've been able to increase the kind of compliance, I think, with those treatment regimens by shifting them towards the front. But certainly those patients with comorbidities and up front, they're difficult and long treatment regimens to get through, and it's still a challenge. So we've kind of tried to shift the sequence in which we do the same things to try to improve that compliance over time, and that's been pretty effective.
Mm-hmm.
Could we sneak in one more quick question?
I'll allow it.
The question, okay, great. Real quick, Dr. Martin. So if you could clarify, what type of hyperthermia do you use in that treatment?
Yeah, so it's not like boiling here. We're talking about like 38 degrees Celsius, something along those lines. I think that equates out to I think it's in the low, 100 degree, 101 Fahrenheit, something like that. It increases the permeability of the tissues to the chemotherapy, and has been shown to increase the effectiveness of it. So, within surgery, you're trying to cytoreduce or get every little piece you can. You're not getting every cell. So the chemotherapy is really designed just to get any of those microscopic cells that are remaining, and the heating the chemotherapy seems to be beneficial in that regard.
That's great. So it's about as warm as a low-grade fever.
Yeah.
So it sounds like.
Exactly.
Perfect. Anything else, Han-Lyn, or shall we move to Dr. Selby?
Yeah, that's it.
Perfect. Well, our cleanup batter for this evening is Dr. Luke Selby. Dr. Selby is a board-certified general surgeon and surgical oncologist and is an assistant professor of surgery at the University of Kansas Cancer Center. He attended medical school at New York Medical College and completed his general surgery residency at the University of Colorado, and then his complex general surgical oncology fellowship at the Ohio State University Wexner Medical Center and James Cancer Hospital. As a dedicated surgical educator, he received teaching awards at University of Colorado and at The Ohio State. His clinical and research interests include skin cancer, soft tissue sarcoma, gastrointestinal cancers, and also the genetics behind cancer development and different cancer behaviors. Dr. Selby, welcome. Thank you so much for sharing with us this evening.
Yeah, thank you for having me. It's a pleasure to be here, and it's great fun to get to follow Dr. Martin and Dr. Kilgore, and to say that I'm batting cleanup. I don't know. It's a hard act to follow. But I'm going to be talking to you about what we know, what we don't know, and what we wish we knew about cutaneous melanoma surgery. And just one point there, I'm going to sort of interchangeably say melanoma and cutaneous melanoma. I have no disclosures, but when we talk about melanoma, when people say melanoma, what they're referring to is almost always is a type of skin cancer. You can also get a cancer that behaves differently but looks the same under the microscope in your eyes, and then in your mucosa, which is the lining of your mouth and your GI tract and your anus. So most of the slides here just say melanoma, but just to make the point that when I say melanoma, or when the slide says melanoma, you can assume I'm talking about cutaneous melanoma, which is one of the least common, but the most deadly form of skin cancer. And so we have, depending on how you count it and how you estimate it, we have at least 100,000 cases of cutaneous melanoma diagnosed in the US every year. Of those, just over 7,500 patients will die of their disease. The incidence of melanoma has been increasing by about 5% a year for the last several years. And in fact, between 2011 and 2021, the incidence has gone up 44%, which is to say we have almost twice as many new cases of melanoma diagnosed now as we did 10 years ago. And we really don't know why. Melanoma is in general, but is not exclusively a disease of blonde-haired, blue-eyed people like I am, or like I used to be when I still had hair. But certainly, regardless of your complexion, you are at risk for melanoma. And the most important thing, and what a trend that I'm going to talk about over and over again, is that the treatment of cutaneous melanoma has been revolutionized over the last 5 or 10 years. And it's been revolutionized not by markedly better surgery, but it's been revolutionized by better medications. And we're now at a point where we have cured patients with metastatic melanoma, where it's spread from their skin, wherever they got it, to distant organs in the body. And even those who can't be cured, we have the ability to extend their life and improve the quality of their life and get disease control for years and years and years. And this was we didn't have this ability when I was in medical school. That's how new these drugs are. Very, very broadly. And each of these slides, my residents will tell you, each of these slides can be an hour rant of mine if I want it to be, but very broadly, melanoma is a surgical disease. Your best chance for cure is with surgical resection. And we try and save other therapies for more advanced disease. Now, I should say, as we get better at using these other medications, we are introducing them sooner and sooner. So when these medications were first introduced, they were only used in patients who had metastatic disease, where the melanoma had spread from their skin to their lymph nodes and then all the way to other organs. When we learned that they worked in that population, we then started using them in patients where it had spread to their lymph nodes. And we're now actually using it in patients where it's just confined to the skin, just based on the aggressiveness of their initial biopsy. And that change has happened in the last several months. And so these medications are broadly a category of medications we refer to as systemic therapy. And depending on the specifics, it's either an injection that's given once every 2 weeks, once every 3 weeks, or a single medication, or some combinations, or pills that you take every day. And this is based on tumor specifics and a specific conversation with you and your medical, or with a patient or medical oncologist. When it comes to melanoma surgery, we make our surgical decisions based on 2 factors. The first one is the depth of the melanoma at diagnosis, and we measure melanoma depth in fractions of millimeters. So a melanoma that is 0.8 millimeters thicker, we think of as being an intermediate thickness melanoma. And then the other question we worry about at the time of surgery, and that changes a lot of our decisions, is whether the regional lymph nodes, so the lymph nodes under the armpit or in the groin or in the neck, whether we can feel those. If we can feel those, that's a branch point. And if we can't feel those, but then we decide to do a sentinel lymph node biopsy, which Dr. Kilgore talked about earlier, it's almost exactly the same procedure in the melanoma world. When we do a sentinel lymph node biopsy, if we find melanoma in those nodes, that's another treatment branch point. If you have clinically negative nodes, so I can't feel anything when I'm meeting you in clinic, we proceed directly to surgery, and that's surgery to take off the melanoma on your skin wherever it is, and then depending on the depth, like I said, above 0.8 millimeters, we would talk and almost always recommend doing a sentinel lymph node biopsy. If you have clinically positive nodes, I'm going to talk about this later because this is an area of active research literally today at KU. We have a clinical trial open that is trying to answer this question for us. Systemic therapy, as I said, this is medications, either injections or pills that you take and that spread to your entire body. Immunotherapy, this is a class of medications. You've seen these advertised when you're watching TV. They actually themselves have no direct anti-cancer properties. So it's not like the chemotherapy of old that would make your hair fall out and give you neuropathy, that was just going at attacking rapidly dividing cells. What immunotherapy does is it turns off the mechanism that melanoma and many other cancers use to hide from the immune system. They have absolutely revolutionized the treatment of melanoma and many other cancers. They do take several cycles to show activity. So if you get an injection on Monday, they're not working on Monday, but they will work in a couple cycles, and they do seem to have very durable activity. We also have a class of medications called targeted therapies, and these are used to take advantage of the fact that about 50% of melanomas have a very specific mutation that changes the way the cell regulates its normal divide and stop dividing mechanisms. And it turns these mechanisms on. And so we have a combination of pills that turn these mechanisms off. These actually do work instantly. So if you start taking these pills on Monday, on Tuesday, they have some anti-cancer activity. Unfortunately, they do all seem to develop resistance. All melanomas develop resistance, and they don't develop resistance in a predictable way that we can then give you some third medication to avoid that resistance. I'll talk about this a little bit more in the future in a couple slides. What we don't know is whose disease will either come back or spread after surgery. And this gets us to a problem where even if you're a really high risk melanoma patient, and let's say we think your risk of recurrence is 50%, what that means is your risk of not recurrence is also 50%. Dr. Kilgore talked about one molecular test that the breast surgeons have, or the breast surgery or breast cancer team has access to, called Oncotype DX. And that's actually a test that helps us narrow down or helps us get a little bit more specific on your risk of recurrence, and gets used by medical oncologists every day to decide if your risk of recurrence is high enough to need systemic therapy. We don't have that in melanoma. And what that means is if we have a group of 100 patients who have a high risk of recurrence, we know some of them are going to recur, but we just don't know which ones. So we end up giving, or at least recommending, taking systemic therapy to all of them. The problem with that is if you're never going to recur, then a medication to decrease your risk of recurrence can't benefit you because you were never going to recur in the first place, but it absolutely can harm you. These immunotherapies turn on the immune system. And so the side effects for these immunotherapies are any autoimmune disease you can think of. And those, some of them are relatively inconsequential, but some of them are really quite strong. And this was not a problem we had in melanoma 5 years ago, because in melanoma 5 years ago, we didn't have medication that worked. Now we have medication that works. So we have the wonderful issue of trying to figure out how to better pick what patients to give it to. It's a problem, but it's, you know, if you go back 10 years, this is a problem that everyone involved in melanoma treatment would have 10 years ago would have been really happy to be struggling with now. And we're struggling with it, and we'll get there. And then 3 things we wish we knew, and this is where I'm going to spend the rest of the talk, is on margin width. So how much normal tissue to take when I do an operation. And then for patients who present with positive nodes, so where they have melanoma that's spread to the regional lymph nodes at the time of diagnosis, what order to give them treatment in. And then for patients who have this mutation where I can give you targeted therapy, whether to give you melanoma, or whether to give you immunotherapy or targeted therapy first. I'll give you some thoughts on that. So right now, if you come to see me with a melanoma, we'll talk about how I have to take your melanoma out, and I have to take out a rim of normal tissue around that. And I take, depending on the depth, 1 centimeter or 2 centimeters of normal tissue in every direction, which generally, by the time you include the scar from the biopsy, ends up being a circle somewhere between 3 and 5 centimeters in diameter. So about 1.5 inches up to 3 inches in diameter. That pretty quickly, for those of you doing the math in your head, becomes a relatively big wound that then, depending on where it is hard to close. And so over the years, we've done a lot of studies narrowing down our margins. And what we found is that, and what you can imagine is a bigger margin is a bigger scar, and is also then a higher likelihood of wound breakdown or needing a complex reconstruction. So a small margin, or even a big margin, if it's on your chest, I can close that easily. I won't have to do anything fancy. But the same margin on your forearm, you're almost certainly going to require a skin graft or some other complex reconstruction. That makes surgery a little bit more complicated, and then that makes your recovery a little bit more complicated. The other thing we know is 6 previous clinical trials have been done that have compared a big margin to a small margin. And in each of those, the small margin has been better, which is to say the surgical outcome was better with a small margin and the cancer outcome wasn't worse. So we have a trial that's already open in Australia. Australia has a very, very high rate of melanoma, and therefore is a sort of international center of excellence when it comes to cutting edge melanoma research. There's a trial that's opening there that's supposed to be opening at the US, and we're already on the list to open it. And it's going to be soon, and I put soon in quotes because it's been supposed to open soon for 6 months. But it's going to be taking patients who fit some inclusion criteria and assigning them to either 1 or 2 centimeter margins to try and answer this question. So we're really looking forward to that. And then the next question for patients who present with palpable nodes, should they get surgery first or should they get systemic therapy first? Historically, we've always done surgery first. And the argument for that was, well, you had melanoma and we know where it is and we can go take it out, so we should go take it out. The problem with that is it removes the lymph nodes, and the lymph nodes aren't these just random little tissues. They're an organ, and they're part of a very complex system, our immune system, that's designed to protect us, right? So the immune system's only job is to recognize self from not self and kill the not self. It helps when you have a bacterial infection, but we also now know it helps when you have cancer. The immune system, immunotherapy is turning on the immune system and has revolutionized the treatment of multiple solid tumors. And so a lot of us have started to believe that the first thing in the treatment should not be taking out these lymph nodes, but it should be priming the immune system, getting the immune system going teaching it what to recognize and kill, and then going in and taking it out. Again, we do not know the answer to this, but we have a randomized trial that is open here at KU that takes patients who fit the inclusion criteria and randomizes them either to surgery first, followed by a year of immunotherapy, or 3 doses of immunotherapy, followed by surgery, followed by the rest of the year of immunotherapy. So the patients get the 2 ingredients that we know are essential to their care. We just don't know what the best order is. And this study is hopefully going to answer it for us. And anyone who comes to my clinic who meets the inclusion criteria, I offer all of them enrollment. It is the first step of my conversation. Unfortunately, a fair number of our patients don't want to enroll in the study, not because they want surgery first or not because they want immunotherapy first, but because they don't like the notion of not having decisional control over what's going on. I've had several patients say, oh yeah, I'd love to do the study and I want to be in the immunotherapy arm. It's like, no, the whole point of the study is you don't get to pick. And the reason for this trial and for any other clinical trial, and I know you all know this, but the reason we have to do that is the whole point of a clinical trial is to take a question that we don't know the answer to, take a large group of patients and get them equal or as equal as they can be in every characteristic other than the characteristic we're trying to control. So in SWOG 1801, it's the treatment order. It's the treatment sequence. And by taking patients and randomly assigning them in one group or the other, we know from very complicated statistical techniques that lots of things are going to match, not only stuff we can measure like the depth of their melanoma or their age or whatever, but also all sorts of things we can't and don't measure. And so that's why randomization is so important. But even with that understanding, there, it's so hard being a cancer patient. You have so little control that patients are really very hesitant to give up that last little dime of control that they have. And then the last thing I'll talk about is, so for patients who have this mutation that turns on their cell's ability to divide, where we have a medication that can turn it off, we know immunotherapy works for everyone with melanoma. We know the targeted therapies work for this 50% of patients, but we don't know which one to start with. We know immunotherapy takes a while to work, but has a quite durable response. And we know the targeted therapies work instantly, like literally if you take a pill on Monday, on Tuesday, we see evidence of your melanoma starting to die, but all melanoma develops resistance. This we sort of know the answer to. There was a trial that was done that within the last year has published their very preliminary results. They haven't written the full paper yet. And so one thing Dr. Martin and I teach all our medical students is don't just read the abstract of the paper, you have to read the whole paper. And while that's true, I'm going to tell you what the abstract showed was that immunotherapy provides a much longer survival. And these were metastatic patients. So these were patients where the melanoma had spread to a distant organ. Patients who got immunotherapy first, more of them lived longer, but within the first 10 months, patients who got the targeted therapy first lived longer. And probably what that means to us is because the targeted therapy works so quickly, even all metastatic patients aren't the same. So if you have a low burden of disease, and we would expect that your lifespan would be at least 10 months, we should start with immunotherapy. But if you have a really, really high burden of disease and we need to get something in you today that works today, we should start with the targeted therapy. And then the last thing is, and anytime I talk with a medical oncologist on the call, I feel very obligated to say, you should not take medical oncology opinions from a surgical oncologist. And so, all of these decisions at KU, they're all made as part of a big group. Certainly with the patient at the center, but with, our medical oncologists, in this case, who specialize in melanoma, with the surgeons who specialize in melanoma. And when we have these patients, we all get together at a group and talk and argue and discuss. And so with that, happy to answer any questions. And this is my email if you have any questions. You know, at all of these talks, the best questions happen in about 10 minutes. So please feel free to email me and be happy to get you an answer.
Absolutely. Thank you so much, Dr. Selby. I really appreciate you taking us right to the top of our hour. You know, thank you and all of our presenters for sharing your expertise and your time this evening. And I want to extend a special thanks to all of the participants who joined in this session. Gosh, what a great hour we've had. So we really appreciate everyone being here. And while we don't have time for questions, Dr. Selby generously offered his contact information, and he's a man of his word. I can vouch for him. He will answer your questions if they come in 10 minutes, as he predicted. So thank you all. I hope you have a great rest of the week and a great evening.
Thanks to the presenters and to Dr. Libby Wolf-Birchfield. We really appreciate it.
Thank you.
Thanks, everybody.
Bye.